What I'd like to do now is actually invite Chris and Ashley also to perhaps join us up on the seats, and we'll have a little bit of a question and answer panel discussion before it takes us up to lunch. So if you'd care to join us over. And I'll start with the sort of, while you get yourself some water, Chris, there was this piece you talked about, and you things that how that things are convenient for us. When you mentioned, you know, your PIN numbers, and we can remember our car number plates, and they take away these everyday things like tax dis and latterly driving license. This was only, I think, came to me very recently when I happened to be abroad. I was in Mexico, and it was quite interesting that I actually didn't need my credit card even to get a car hire. Everything had been done online, and they checked that I hadn't got points. I got to the hotel, and because I was a member of their reward club, I didn't need a credit card. I could walk into a very nice hotel, they'd give me a room, and I could stay there for as long as I liked. I went to get my coffee from Starbucks, and God's honest truth, my Starbucks app took money off my account in there. But however, crossing the road with my Starbucks feeling good for me, and I looked the wrong way, and I was very nearly knocked over. I'm one of those stupid people too. But had I been taken to the ambulance, they'd have started from scratch. Yeah. And that is, you know, when you think about all the things in the world that we want to put right, there's a good place to start. And this is about, to me, this is the fact that we don't have joined up data in our health service. So now you've had your glass of water, my question is, how do we look at those things? Because you articulated very clearly the need of the interoperability of data from probably pre-admission, through hospital stay, to post-admission, to all that way around. And I like the way you talk about you stand up, you lie in a bed, get you up again. And there's a lot of talk these days about re-ablement, which is this piece about trying to avoid you going back into a hospital again through that. What are the sort of standards that you think we could do, or what is the sort of common thread around data? And how can we make that happen? Because as you articulated well, we've got primary care, we have the secondary care, and then we've got social care and out-of-hospital care, and they're almost, the way we've set them up, competing. So how do we get above that?
I think they are certainly, in my experience, competing. I think, in fact, the competition in the health services has never been more rife than it currently is now, both through providers but also the new institutions. I would say, sort of on a local level, that responsibility lies with appropriate and proper commissioning, and stronger commissioning than we've seen thus far. I mean, you know, the commissioning regime is still relatively new, and I think, again, there are clear pockets of excellence throughout the country. There are also areas where it doesn't function on behalf of the patient. There was something I picked up that was very interesting that I read recently. I can't remember who was the author of the report, but it suggested that really good commissioning should be based on a number of caveats that are around patient experience. So it shouldn't be about the contractual basis of, you know, how many, you know, how much you will reduce your unplanned admissions by, how, you know, quip around, I don't know, number of acquired infections or whatever it may be. It should be around the patient experience. Now, if that is the case, and the commissioner is commissioning across all of primary, secondary care, then in fact, you would have to be able to know how that could be enabled. You'd have to be able to measure that, would you not? So in some way, the provision of that information, it's not data, it's intelligence, needs to be put at some level of access for both the commissioners, the providers, the community trusts, or wherever it may be, but most importantly, to the individual patient. In some way, I think strangely enough, I think the responsibility lies with each and every one of us to do it, not, to my point, not in some way to move the responsibility to organisations. I think we should want it and indeed demand it. And if you look to industry, you know, clearly my background is in a big American corporation, a big worldwide corporation, and, you know, many of you will have come from, or do come from, commercial organisations. You know that, you know, business intelligence, business analytics, data warehousing, you know, we've been doing that for 25 years. This is not new stuff. So it shouldn't be enormously complex to put it in place. And you know, as again, I was delighted to hear the work that Paul and his team are doing, but pace is really important. These things can be done, and I think they can be done relatively quickly. It is about intelligence, not data. That would be my overriding message.
And Ashley, I guess also from your perspective, both working, you know, as you do closely within the trusts and working very much on culture change, that came very, very clearly through. There is a culture in the NHS that healthcare is something that is done to people. So how, from the patient perspective, do you think there is a willingness from the system to accept, if you like, patients who say, well, I want to be part of my care, I want to own my care, rather than this care is something that is done to me in a passive way, which you know, I think is articulated very well.
I think my journey with this and the experiences I've had with other people is that we're changing. The pendulum swing, I reckon, happened about 4 years ago for me, when I started to hear words like emotional intelligence coming into play with our leadership. And I think you have huge pockets of culture in the NHS that are firmly fixed in the past. That, you know, this is what we do, we're doing it to you, you're lucky to be here, this is what we're doing, kind of. And then we're getting now into an era of, you know what, this is all of ours, and emotional intelligence comes into play, and is this really a good choice for you and your lifestyle? So I see both being played out at the moment. And, you know, we're all people, and we've all got a certain judgment on what we would want when we go into hospital. No one really wants to be in hospital or have care. Everyone would choose not to have that. But this pendulum swing for me feels better. It feels like that, you know, people are taking ownership of the NHS more. Apathy's still out there about being involved in it and having a say. But it's a realisation for me that I can be in front of the old school of the NHS, and I'm not disrespecting that. Hugely experienced people with and dedicated their lives to the care of other people, but in a certain regimented way, and this is how we do things, into a new era of people who are set free to care for people in the way that they've been managed by their parents, or the way they see society differently. And for me, it's a huge step forward for the NHS to see that.
Brilliant. So my last question, and then I'll open it up. There is this thing, I mean, it's interesting, it goes through each of these presentations, which is, it comes back, and I think throughout the last couple of days, it comes back to money. And as a not-for-profit organisation, Ashley, GS1 membership organisation, it gives us the opportunity to kind of have a number of discussions that we can have. The serious question is, for both of you, please, to kind of look at, in your experience with the NHS, how much do we think individual polarisation silos of budgets are working to the detriment of patient care? Is that a reality, or is that a myth?
I think that's a reality. I think everything that I come across on a daily basis is financially driven at the moment. And, you know, we have to have grown-up conversations about that it costs a lot of money to run our healthcare system, and people use it inappropriately. There's a lot of waste. It's not managed properly. We could do things more efficiently, etc., etc. And it's the way, I think, if I was in charge of NHS finances and budgeting the books, I'd be doing exactly what Future Focus Finance are doing. Let's say, like, let's all get together and see what we can do differently then, together. There's one big pot of money. Everyone takes a bit of it. But let's have a look at that structure again. Why does that happen? Why have we got so many complex hands on that money before it actually gets to a nurse's pocket or to buy some drugs for me and my family? And that manifested itself into reality for me and my family couple of months back, where my son was turned away from A&E because they couldn't afford a blood test. And I found out that a blood test, about £20 it cost. Couldn't afford a blood test, and so I was forced to take him to another A&E where they operated him immediately for emergency appendicitis. He could have died. And so somewhere along the line, that perverseness of the trail of money and that silo, and it's not yours, it's my budget, and that kind of thing, nearly killed a child. And so while we've got that apparently happening in the NHS, discussions like this have to happen, don't they?
Well, it certainly isn't a myth, or indeed a moth or anything. It is absolutely a reality that the financial challenges, I think, are enormous. I certainly don't disagree with Ashley that, you know, if you put it in the round and say what can we do with this amount of money, you know, you're going to get many million people all having a different idea. I sense there is only one pot of money, that's for sure. I think, irrespective of the rhetoric, it's not going up. It's pretty much static, and I don't believe it necessarily will. Irrespective of, I think, political will, it probably would like it to, it is just not affordable, in my view. And I think other health systems are finding exactly the same. I suppose I like what's been done in Manchester, in a sense. I think in some way regionalising healthcare, I think, is certainly important. You know, my trust is only just down the road. It's in a recognised challenged economy. Staffordshire, clearly Staffordshire has got a particular ring about it to most people in the health service, just down the road in Stafford itself. It is completely different, the provision of healthcare, and indeed that demographics, than in the southeast necessarily, or certainly in an inner city, London, Liverpool or elsewhere. So I do like regionalisation. I think currently, you know, I don't disagree or agree really how the money actually gets to the patient through whether it's commissioners or otherwise, but I don't think there's any discipline around that. There's actually nothing from a corporate point of view that holds the reins. And it was something that was said yesterday by Neil last night, who said, you know, even in, I think, his retail industry, he said they don't tell everybody what to do on a regional or individual basis, but he certainly knew corporately what is the right way to, for instance, perform health and safety. And I think that's important, that actually we lay those things down in the health service. The one thing I do think that exercises me around the changes, particularly in the forward plan, and the changes that I would advocate to move, particularly the frail elderly, to manage the frail elderly in their homes, if you wish, but in the community, is I wonder over time, and it's just, you know, it's not a negative view, I wonder over time whether that particular piece of cost, of health cost, will move it to the individual. So if the ownership moves for your own care, is what I'm saying, if it's self-care, I would not be in the least bit surprised if the cost for that care in somehow starts to reside with the individual. And I'm not suggesting it therefore turns into an insurance-based system, but I think you will have a mix, because I'm pretty sure, when there's no evidence, that with the exception of moving unplanned admissions out of provider trust, which will, Simon Stevens says, will save 22 billion, right, out of provider trusts in particular, there's no suggestion that money will move to actually managing care at home or elsewhere. So there's no suggestion about reinvestment currently. So I think we've got a significant discussion to have around affordability as a society.
Thank you. time for a couple of questions from the audience before lunch. Who'd like to have a go first? You can't all be scared of me and my catchbox. Oh, and if so, you could say your name. I'm going to chuck that. I'd keep out of the way if I were you, because I'm not good at this. There we go. Oh, look at that, brilliant, well done.
Thank you. My name's Mark Oldham, I'm the Finance Director at Mid-Cheshire. I'm heavily involved with the Future Finance, Focus Finance stuff, so welcome your endorsement of that, Ashley. Question is for Ashley, really, in terms of taking this to its natural conclusion around the economics and potential rationing then of healthcare, and the engagement with the public on that and having that discussion. What do you think the sort of public appetite is for that? How do we get to the public to that sort of position?
Really good question. So if we go back a year and a discussion we first had in London with the Future Focus Finance people, there was an assumption that the strategy going forward for Future Focus Finance was going to be based on assumption that everyone knew everything there was to know about NHS finances. And I challenged that assumption. I said, well, hang on a minute. How can we base a 5-year plan going forward based on assumption? I guarantee you people don't know about NHS finances, and we went out to prove it. So Sam and I, who's going to be speaking later, have gone out across the country, and so I was trying to find what knowledge there is. And so in the rooms, we had patients, public and employees of the NHS joined in, asking questions. How much does a nurse earn? How much is a hip operation? How much is a GP appointment? These kind of things. Just basic knowledge that people should know. And my assumption was right. Nobody knows anything really to do about the NHS finances. When you tell people 107 billion, some people you have to explain what that figure is. You know, they don't understand what £1 billion is, some people, you know, but that's not their lack of intelligence or knowledge. But they've never thought about it. And when you start pointing out how much money we spend, you know, against defence or education, and, you know, people start getting interested. And they say, well, why don't we know this information? Why don't politicians talk about that? Why aren't we hearing about this, how much we're spending? The interest in the room is up there. How can we find out more? What can we do? And that's one of the points of engaging the patient and public of this country in this discussion. Because I think we've touched on it. This isn't just 15,000 people in the NHS's job to worry about how we're going to spend money and the procurement process and, you know, efficiencies. This is 65 million people's concern. We all need a say. We all need to join in and help save the NHS's finance, don't we? And, you know, when you explain it to people, we all assume that they won't understand what we're talking about. But you explain it in a clear way that this is what's going on, how much, and this is how the way the money comes from our taxes to that nurse's pocket. Everybody gets it, everyone understands it, and everyone's got a view on it. And everyone wants to save money, and everyone can get what we're talking about. I think some of the best work that I've done in the last 5 years definitely has been engaging people into the finance conversation of the NHS.
I think that the NHS tends to, So we have an internal debate, and it goes on and on and on and on and on. We internalise every single issue that we have instead of externalising it. And I think across the total population that's difficult. I'm not suggesting it shouldn't be done, but I think it's difficult, and it will inevitably be in some way politically motivated. That's why I think doing it at regional level is, because actually at regional level it matters, because that's where you're, irrespective of the mobility issue, which is really about people travelling more, but that's what matters to you. It's where you're likely to have your care delivered, and therefore you should care, and you should actually determine what that looks like.
Good question, Mark. Thank you. So, gentlemen, please, can you thank Ashley and Chris for their contribution? So now is time for lunch, and just before I let you go for lunch, I just kind of want to just reflect on this morning. And you know, yesterday was definitely a day of strategy and of policy and of implementation. And I think, as you can see this morning, we've talked an awful lot around culture and actually had some brilliant insight and thought leadership. And that will actually continue this afternoon with our speakers this afternoon. We have 3 speakers in one session this afternoon, and that's going to kick off with Dr. Peter Brambleby. We'll then have the much mentioned Sam Sherrington to talk a little bit about future focused finance. And then we round off, as I mentioned earlier, with Fergal McGroherty from Dublin. So lunch is now. For those of you that are booked in on our sponsors' lunchtime breakout sessions, these are the rooms that they're in. Those sessions will commence promptly at 1 o'clock. So we're back in the room here promptly at 1:30, so we can get everyone out of here certainly promptly at 3:30 this afternoon. So thank you for your attention this morning. Enjoy your lunch, and I look forward to our continued debate this afternoon. Thank you.